Hello and welcome to today's webinar, Quality Improvement and Implementation Science, sponsored by Elsevier's Clinics Review Articles and Anesthesiology Clinics. Please note, your line will be muted and the presentation will be recorded. You may submit questions at any time using the Q&A feature located on the right. Today's presenters are Dr. Meghan Lane-Fall and Dr. Lee Fleisher. Thank you for being with us today, Dr. Lane-Fall and Dr. Fleisher. Meghan Lane-Fall, MD, MSHP, is a physician with a deep and abiding commitment to providing safe, effective patient care. Her research agenda is focused on the scientific study of strategies to support the safe and high-quality care of hospitalized patients. Dr. Lane-Fall is the founding co-director of the Center for Perioperative Outcomes Research and Transformation, an assistant professor of anesthesiology and critical care at the University of Pennsylvania. She is a board-certified anesthesiologist and surgical intensivist whose main research interest is improving healthcare provider communication at times of transition or handoff across sites of care. She employs qualitative and mixed methods to develop effective communication strategies that incorporate human factors principles while complementing clinician workflow. Her work is best characterized as healthcare delivery science, falling at the intersection of improvement science and implementation science. Dr. Lane-Fall is also interested in building research capacity in healthcare services research. She mentors research fellows and clinical trainees and is a co-course director of Penn's graduate-level implementation science course. Dr. Lane-Fall received her AB degree with high distinction from the University of California at Berkeley. She received her MD degree from Yale University, where she was elected to the Alpha Omega Alpha Honor Society. She completed anesthesia residency, critical care fellowship, and research fellowship at the University of Pennsylvania, during which time she completed a Master's of Science in Health Policy Research. She was elected to the Association of University Anesthesiologists in 2015 and to the Anesthesia Patient Safety Foundation Board of Directors in 2017. Lee A. Fleisher, MD, Consulting Editor, Anesthesiology Clinics, Robert D. Dripps Professor, Anesthesia, Perelman School of Medicine, University of Pennsylvania, Chair, Anesthesiology and Critical Care, Perelman School of Medicine, University of Pennsylvania. Dr. Fleisher is interested in health policy and defining metrics around quality of care. He is Chair of the Consensus Standards Advisory Committee and co-chair of the Surgery Standing Committee of the National Quality Forum, and a member of the Administrative Board of the Council of Faculty and Academic Specialties of Association of American Medical Colleges. He is also a member of the Medical Advisory Panel of Technology Evaluation Center of the Blue Cross Blue Shield Association. In 2007, he was elected to membership of the Institute of Medicine of the National Academy of Sciences. Dr. Fleischer's research focuses on perioperative cardiovascular risk assessment and reduction, evidence-based medicine, and measurement of quality of care. For the past 10 years, Drs. Fleischer and Silber have collaborated on numerous projects related to health services research and quality measurement in the Medicare population. Most recently, he has been studying the influence of culture and innovation on care delivery. He has received numerous federal, industry, and foundation grants related to these subjects. He has authored over 300 articles, chapters, and books, and he has served as a consulting editor for anesthesiology clinics for 15 years. And with that, I'll turn it over to our speakers.
Great. Well, we are delighted to be here with you today, for those of you who are here with us live and those of you who will join us in the future. Our comments will start with some prepared slides, and then we'll open up for Q&A. So I will introduce you first to quality improvement and implementation science, and then we'll finish up with some remarks from Dr. Fleischer. We have several objectives for this webinar for the time we have today. The first is that we'd like you to be able to describe what quality improvement and implementation science have in common, And if you're on the webinar, you have a sense that there may be some similarities between these fields. But in my teaching of graduate students and in my working with colleagues, I find that there is oftentimes confusion about what these two fields have in common and what makes them different. The second objective here is for you to be able to describe two factors that distinguish QI from IS. And then the third objective is for you to be able to name one implementation science framework. So the outline for the webinar is as follows. We will first define quality improvement and implementation science, really focusing on implementation science because for the last 2 to 3 decades, there's been a really intense focus on quality improvement in healthcare, and we have a sense that people know what that is, so we'll just review that briefly, but then spend more time talking about what implementation science is, what it means, and what implications it has for care and research going forward. Some similarities between QI and IS, some differences, and we'll finish up with what QI and IS can learn from each other and our own personal perspectives on these two fields. So first, what is quality improvement? The definition offered by the U.S. Department of Health and Human Services is that quality improvement consists of systematic and continuous actions that lead to measurable improvement in healthcare services and the health status of targeted patient groups. And we've highlighted or put in blue here some really key components of this definition. So quality improvement efforts really need to be systematic, so there needs to be a consistent approach to how these actions are undertaken, and they do need to be continuous. So in contradistinction to typical research, this isn't a situation where you identify a problem and one solution and you only implement the solution once. Quality improvement really relies on continuous assessment and it needs to be measurable. Whatever the changes that you're trying to achieve needs to be something. So to get a little bit more granular on what quality means, the Institute of Medicine, which is now called the National Academy of Medicine, defined 6 dimensions of quality. They have 6 domains of quality care. And you see them here in a figure. Basically, quality care needs to be safe, it needs to be patient-centered, it needs to be effective, meaning it achieves the outcomes that we're looking for. It needs to be timely and efficient and equitable. Only when we've achieved all of these domains or all of these dimensions can we say confidently that we've achieved. The way that we get to quality and the way that we improve quality is by using systematic approaches. One of them is called the model for improvement, and so that is the schematic that you see on the slide here. The model for improvement shows us how to specify what we're trying to accomplish, how we'll know that a change is an improvement, and it gets us to ask the question, what change can we make that will result in an improvement? And the way that we get to change is we do rapid cycle tests. Plan, Do, Study, Act, or PDSA cycles, also called Plan, Do, Check, Act cycles. So the idea here is that there is a continuous iterative process of really specifying what the question is, what the problem is, what approaches we will take. We identify solutions, we implement solutions, and very quickly figure out whether our solutions have been effective. If they haven't, then we look for new solutions, and if they have been effective, we think, well, how can we make them even more effective? And how can we spread and scale the change that we've started to achieve? So the tools that we use in quality improvement are, again, these PDSA, Plan, Do, Study, Act, Plan, Do, Check, Act cycles, root cause analyses where we get together as a team and we start with a problem, we start with an occurrence, and we try to understand all of the factors that led into that, and so that's a very commonly used tool in healthcare. There's also a similar concept called an apparent cause analysis, which is a little bit more constrained than a root cause analysis, but it really helps us try to understand why adverse events happen so that we can prevent them in the future. We can also use something called the failure modes effects analysis, which is a proactive approach to identifying potential threats to patient safety, and this is a very involved process. There is an alteration of this called the Healthcare Failure Modes and Effects Analysis that comes out of the Veterans Affairs Administration. But the idea here is that we can break down processes in healthcare to proactively identify potential problems so that we can try to prevent patient safety and quality threats before they happen. And then statistical process control charts is a numeric way, a quantitative way to characterize how we have changed quality over time. And so the idea here, this is sort of a takeoff on a run chart. A run chart is a much simpler version of a statistical process control chart, but it lets us map out over time whether these measured changes actually represent a change or if it's just more of the same. So that's a very quick overview of quality improvement. Again, I think that this audience is familiar with what quality improvement is, and I'd refer you to the Institute for Healthcare Improvement for more granular information about quality improvement and all of the tools that I mentioned very quickly. I have a master's degree and went through a 2-year fellowship in quality improvement and patient safety, and so to sum up quality improvement in 3 slides is very difficult to do, but there are definitely resources out there to dig more into quality improvement. But I'd like to transition now into talking about implementation science, because that's something that's newer and is much less familiar to people that are in healthcare operations, healthcare at the bedside, and then also research. So before I give you a definition for implementation science, I want to sort of lay the groundwork for why we need something like implementation science. And really, implementation science is interested in the gap between discovery and uptake. And so on the slide here, you see on the left, we have evidence that's represented with a microscope, and on the right, we have practice that's represented by the clinician at the bedside. And we know that there are gaps between when we find new evidence and when it's actually taken up at the bedside. And the estimates for how wide this gap is vary, but there's an estimated 17 years between when something is found, when it's published, and when it's consistently used at the bedside. So whether that's giving aspirin after a heart attack, or whether that's avoiding MRIs for uncomplicated back pain without neurologic symptoms. In anesthesia, we have lots of evidence around preventing postoperative nausea and vomiting, and use of neuraxial techniques for pain in selected populations and selected procedures. There are a myriad of evidence-based practices that we've identified that we're confident work. We know that they work in randomized controlled trials. There's no question about whether this evidence is solid. And yet, even when we have solid evidence, we don't always implement it into practice. And this is what implementation science focuses on. So the goal of this field is to bridge the evidence to practice gap. Goal here, so we want to narrow that 17-year gap down to ideally nothing, but something much smaller than that, so that we can actually see patient outcomes improve when we implement these evidence-based practices. There is a lot of both scientific evidence and attention in the lay press to our inability to implement evidence-based practices. And so on this slide, you see 2 examples of that. The one on the left from Vox is pretty recent, from February of this year, of 2018. And it says why American doctors keep doing expensive procedures that don't work. This actually speaks to something we call de-implementation, which is getting people to stop doing things that are not evidence-based, but the concept is very similar. On the right, you see something from Modern Healthcare that talks about physician compliance not being a given with evidence-based protocol changes. Those of us who are clinicians understand that just because there's a protocol that comes along, even if there's good evidence to back it up, we don't always implement those protocols and adhere to them, and certainly our colleagues don't always do that too. So the official definition of implementation science I take from the journal Implementation Science, which is the flagship journal in the field. And this is from the very first volume, from the very first edition, from Eccles and Mittman. And they define implementation science as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice, and hence to improve the quality and effectiveness of health services and care. So again, I've highlighted some keywords here. This is a science. So just as you would apply the scientific method to any other question, we apply it to implementation science here. So we're trying to build up the empiric body of knowledge about how to get clinicians and other people who are taking care of patients to do evidence-based practices. Like quality improvement, implementation science is meant to be systematic, and it's meant to improve quality and effectiveness. So you can already start to see some parallels between quality improvement and implementation science here with the definitions, but we'll dive a little deeper into what the similarities and the differences are. So this schematic comes from a paper that's about implementation science and about dissemination, and it really shows the relationships between efficacy, effectiveness, and implementation. And so just to step you through this schematic, along the x-axis you have time, and along the y-axis you have real-world relevance. And you can think about this as the evolution of an evidence-based practice. So Here they use the word program because this is focused on public health or mental health, but we can put any sort of intervention in there. So you could even say drug. Could a drug work? So that's at the very beginning of inquiry. So we're all the way on the left in the x-axis for time. And as we're doing the foundational work, we're less worried about real-world relevance, and we're really more worried about how do we know that the thing actually works? What are the mechanisms by which it works? What's the foundational work that we need to do? So for a drug, it may be animal studies. For for a protocol that we're hoping is an evidence-based protocol, maybe it starts in one particular ICU or it starts with a very particular patient population. And we do some foundational work to understand mechanisms. We move on to efficacy studies, and so this is where our randomized controlled trials come in. So we have our ideal populations. We've excluded 90% of the people that look like the people we normally take care of, because we want to compare apples to apples. And so we do these idealized studies where we test our intervention against either placebo or standard care or some other valid comparator, and we do what we call efficacy work, which is understanding, can it work in the way that we think it works. Once we've demonstrated efficacy, we can then move forward to effectiveness. So you see we've moved along in the x-axis in terms of time, and we moved up in real-world relevance. So effectiveness is like efficacy in that, except that we have relaxed our inclusion criteria. So maybe it's not a randomized controlled trial as sort of classically conceived. Maybe it's a pragmatic clinical trial, and we've loosened our inclusion criteria, but we're trying to figure out, does this intervention work in the real world, or could it work in the real world? And then beyond effectiveness, we have this big yellow box of implementation. So once we know that it works in theory and it works in practice, the questions then become, how do you get people to take up the evidence-based practice and to actually do it? And so concepts of exploration, meaning the sites or the clinicians thinking about taking this up, actually deciding to take it up, doing it, implementing it, and then sustaining it. So continuing to use the evidence-based practice. All of these concepts are related to implementation. And I've added one little piece to this schematic, which is that down blue arrow that says de-implementation. This was not in the original schematic, but increasingly as we in implementation science think about challenges to implementation, we realize that de-implementation is really important too, because as our science evolves, as our evidence evolves, we realize that not all quote-unquote evidence-based practices remain evidence-based, or we have some new, very important information that tells us that we shouldn't be doing those practices, and we have to think about how to get people to stop doing things they have done. And we don't think that implementation and de-implementation are necessarily two sides of the same coin. They're certainly conceptually related, but it's possible that the processes that we have to take to get people to stop doing something are different than the processes we need to, or the steps we need to take to get them to do something. That's still very much an active topic of discussion in the implementation. So who should care about implementation? When I usually have a slide like this, I animate it so you can see one box at a time, but you sort of see the whole spectrum here. The idea is that really everyone should care about implementation. So if you are a patient or a family member of a patient, you should care that your clinicians are not necessarily giving you the best care, that you're not receiving evidence-based care, that there are challenges to implementation that sort of prevent you from achieving the best possible health outcomes. If you are a researcher, especially I would say if you're a researcher who's in the early stage of the translational spectrum, so if you're doing some of that foundational work around efficacy, you should care that your work is actually not getting translated and is not reaching patients. And so it's important for people who are making these discoveries to think about, well, how can I situate my work and explain my work and contextualize my work so that it is implementable, and how do I help break down the barriers or work with people to break down the barriers to get my work into practice. If you are a clinician, you should care that you're not necessarily delivering evidence-based care, and I think all of us as clinicians want to render care that is likely to achieve good outcomes for our patients, whether those outcomes are a return to health and function, or I work in the ICU quite a lot, and sometimes we have patients who don't make it out of the ICU, then the outcome is a good death, or taking care of the patient according to their wishes. So we can define outcomes really broadly here, but if you're a clinician, you should care that you're potentially not delivering the highest quality evidence of care because there are challenges to implementation. You are a payer, you are financing all of this care, and so ideally you're trying to achieve outcomes for your population at the lowest possible cost. And non-evidence-based care may lead to problematic outcomes and may decrease the return on your dollar and decrease the value of the care that you're funding. And so payers increasingly are concerned about implementation gaps. And then finally, regulators. So if you're in the United States, it could be the Joint Commission, it could be the Accreditation Council on Graduate Medical Education, it could be the Centers for Medicare and Medicaid Services. But regulators ideally want to make sure that patients are receiving high-quality care, and they want to hold health systems and healthcare providers accountable, and so they are as well. So hopefully I've convinced you that no matter where you sit on the spectrum, you should be concerned that there are evidence-to-practice gaps, and you hopefully believe that implementation is something that you should care about. So implementation can fail for a lot of reasons, and there are many models and frameworks, and I'll go through a few of them later, but it's not trivial to think about the evidence-to-practice gap and the reasons that we don't always implement best evidence. So the REAIM framework is one way to think about that, and if you can see on the slide inside that little black pentagon, it says reaim.org. There's more information about this particular framework. But basically, you can think about, does the evidence-based practice actually reach the targeted population at all? Does it work in a given population? Do the clinicians actually adopt the practice? Do they implement it with fidelity? Do they implement it the way it's supposed to be? And even if they do implement it, do they actually keep doing it? And if there are problems in any of these components of the Pentagon, you can see that gap will persist, the evidence-to-practice gap will. So similar to the commonly used tools that we talked about in quality improvement, there are commonly used tools and concepts in implementation science. The use of theories, models, and frameworks is really important, and I'll talk about that moving forward. And also the use of mixed methods, both qualitative and quantitative methods, and I'll explain why it's important that we use. So I mentioned a couple of times theories, models, and frameworks. The picture I have there on the left is George Box, who's a famous statistician, who said all models are wrong, but some are useful. And that is certainly something that implementation scientists take to heart. When we talk in implementation science circles, we tend to frame our comments in relation to frameworks that help us sort of have a common language around what implementation science is and what constructs we're looking at, but there are many different ways that you can design theories, models, and frameworks. And the schematic you have on the right there from Per Nilsson from a paper in implementation science is a really great breakdown of the different types of theories, models, and frameworks. So the first gray box at the top there says theoretical approaches used in implementation science, and then he breaks those down into three buckets. One is models that describe and or guide the process of translating research into practice. So these are process models. Those of you who are familiar with conceptual models or logic models, these are the schematics that have arrows in them, that speak to causality, that help us start to talk about how different ideas relating to implementation relate to patient outcomes. When we think about, so the second bucket there is understanding and or explaining what influences implementation outcomes. And here, these models tend to be more groups of factors. The most important one is probably determinant frameworks. And so for those of you who have heard of CFR, or the Consolidated Framework for Implementation Research that came out of the Veterans Affairs Administration, Laura Damschroeder headed up that team. These frameworks don't have any arrows in them. They're just sort of lists of buckets of things that you need to consider with implementation. So for CFR, for instance, those buckets, those 5 domains that Laura Damschroeder talks about are the outer setting, the inner setting, the characteristics of individuals who may have to implement, the process of intervention, and the characteristics of the intervention itself that you're trying to implement. Within those 5 domains, there are now something like 36 to 40 different constructs, and there are subconstructs, and without getting too far into the weeds, the idea here is that we can list out all of the different factors that may influence implementation, and once we list them out, we can determine how to measure them, and then start to influence those measures and try to affirmatively and actively influence implementation and get people. third bucket over here is evaluating and implementation. And so evaluation frameworks they're sort of similar to process models, but the goal here is really to think about something that's already happened and to try to help understand whether it was successful in achieving its outcomes and trying to break down all the factors that led to whether it achieved its outcomes or not. And the REAIM framework that I showed you earlier has been used in an evaluation setting. I also want to talk about mixed methods. So I mentioned how important it is that we use mixed methods approaches. And this sort of confusing looking 2x2 table gives you some idea about the complexity of mixed methods. So the idea behind mixed methods is that you're using both quantitative approaches, in which the data are numbers. You can use inferential statistical testing and all of the approaches that I think a lot of us are familiar with if you're familiar with biomedical research. But you also use qualitative data as well. And after this slide, I'll go a little bit more into what qualitative research is, because I think, especially in anesthesia audiences, they tend to be less familiar with qualitative research. But the idea behind mixed methods is that you learn more from mixing the methods, mixing qual and quant together, than you do from either in isolation. There are actually a lot of ways that you can mix them. So as you look at this 2x2 table, you see along the rows, there's a decision that a researcher has to make about which one is more important. So paradigm emphasis. Are you more interested in qualitative methods, or are you more interested in quantitative? So you can see along the top row, you can design a study such that they have equal status. Equally interested in the qualitative outcomes, the qualitative characterization of the phenomenon, and the quantitative outcomes. In the second row, you can see that you can choose to have one of them be dominant. So you can choose to focus on qual. So this might be an interview study where you do a very small survey component. You have a survey that maybe has 2 questions on it. So mostly you're focusing on qualitative concepts, but you may build in a little bit of quant. You can do the opposite too. So a survey is another good example here. Maybe you have a 20-question survey about a particular concept. So you survey anesthesiologists about how likely they are to use a nerve block for hip fracture. Maybe 18 of your questions are closed-ended questions that can be counted, and then 2 of your questions are open-ended. And so you do some sort of qualitative coding procedure to look at the responses that people give you from their qualitative questions. That could be an example of quantitative predominating. When you look along the columns, you see that there's a time order decision that has to be made. You can do mixed methods concurrently, meaning you're collecting qual and quant at the same time. So for the survey example I gave you, that would be concurrent. But you can also do them sequentially. So you can do qualitative first and then quantitative. And the reason that you might want to do this is an exploratory sequential model is qualitative than quantitative. So one thing that I've done in the past is an interview study of attending ICU physicians trying to understand how they approached handoffs. And so we started off with interviews, and then we used the interview findings to create a survey, which then helped us understand the prevalence of different handoff practices. So you explore with the qualitative, and then you define with the quantitative. But you can also do something called explanatory sequential, where you start off with the quantitative, and maybe you find you do a secondary database analysis looking at the association between patient age and the use of postoperative nausea and vomiting prophylaxis, for instance. You find an association, you can then do observations or interviews or some other qualitative approach to understand why you found what you found. So there are a lot of different ways to use mixed methods, but it's a very powerful way to understand a phenomenon very deeply. So I've talked about qualitative research, and again, I think in anesthesia and perioperative audiences, it's sometimes useful just to give a very quick primer to what qualitative research is. So qualitative research is research in which your data tend to be non-numeric. So it could be words, it could be ideas, it could be images. It tends to be purposive, meaning that we are sampling because we're trying to find out about a particular phenomenon. And it tends to be hypothesis and theory generating as opposed to hypothesis and theory confirming. So the idea here often is that we're trying to explore the universe of the phenomenon. We're trying to really understand it very deeply, but we're not necessarily trying to say definitively that we know that X causes Y. Qualitative research is very useful for understanding the scope of a phenomenon, And so if I reference the study I talked about before, the interview study I conducted of attending ICU docs, I had no idea what their handoff practices might be. You know, I'm an intensivist as well as an anesthesiologist, and I know what my handoff practices are. But if I'm trying to understand what's happening around the country, I don't really even know where to start. And so taking a qualitative approach can be really useful to understanding the scope of the problem or the scope of the. And as I mentioned before, in an explanatory sequential mixed methods mode, qualitative findings can be very useful for understanding quantitative findings. You can certainly start with a quantitative approach. When you find an association or perhaps don't find an association, you can then use qualitative approaches to try to understand what you found with your quant. What I do want to say, though, is qualitative research is not arbitrary. So some of the decisions that are made in qualitative research can seem arbitrary if people don't specify why they're doing what they're doing, but it's not meant to be that way. About how qualitative research is not usually hypothesis confirming. It's often also not generalizable, but that's not really the point. The point, again, is to understand the scope and to generate hypotheses. And as someone who reviews for anesthesia journals, I sometimes see other reviewers criticizing qualitative research as not generalizable, but oftentimes that's really not the goal. But that's one of the reasons that qualitative research, in combination with quantitative research, hopefully I've relayed to you this fourth bullet, that qualitative research is not contrary to quantitative research, that you can actually use in a powerful way. When we do qualitative data analysis, we call that coding. And what coding looks like, so this is a screenshot from a software program called NVivo, which is a very commonly used program to do qualitative data analysis. When we're analyzing qualitative data, we're often doing data reduction. So we have hundreds or thousands of pages of text that we then need to make sense of. And the way we make sense of that is by creating categories. And that process is called coding. So what I'm showing you here on the left side of that screenshot is a transcript from one of these attending interviews. And on the right side, see what we call coding strips, which are just notations of the categories that we've made. And you do this process iteratively in qualitative research. Once you have these categories, you can collapse them into subcategories and start to make sense of what your participant has told you or of what you found. So coming back to implementation science, the reason I wanted to talk about mixed methods research is that we use this a lot in implementation science. There are multiple ways, both qualitative and quantitative, to assess implementation outcomes. And Enola Proctor, in the first reference on the slide here, talks a lot about implementation outcomes. And there are 8 to 10 sort of classically conceived implementation outcomes. And I won't go through all of them, but some of them include acceptability and feasibility and appropriateness. And there are not as many validated measures of these outcomes as we would like. So sometimes we have to characterize them qualitatively because we don't have another good way to do it. But another reason to use qualitative approaches is that the qual gives us much more richness and understanding of what the numbers are telling us. So if you're interested in implementation outcomes, you can do interviews and focus groups, observations, or document review, whether that's chart review or looking at people's notes. And if you want to quantitatively measure implementation outcomes, there are some measures that are available, including the 3 that are listed on this slide that come out of Brian Wiener's group. And increasingly, there are more quantitative measures of implementation. This is an active area of inquiry in implementation science, figuring out how can we quantify outcomes that are relevant to implementation. I want to show you another example here of the power of using mixed methods. And so this is data from a study of operating room to ICU handoff standardization that we've done at Penn. Some of the findings from this study have been published, but these particular ones haven't yet. So we were trying to understand why people might or might not adhere to a standardized handoff process that we created. And on the left, you have a snippet from an interview that was done with an anesthesia resident. We said, so this resident said, I think ultimately we have to be clinicians and do what we think is best for the patient and not just follow a checklist just because that's. So you see a little bit of skepticism here about following a checklist, but some sense that they really do want to do the right thing for the patient. On the right, you see a graph that shows fidelity to our handoff process. So the process we designed has 10 different steps to it, And what you're looking at is a histogram superimposed on a line graph that shows you whether people actually adhered to it or not. And so we see the histogram bar stacking toward the right. We see that for the most part people were adhering to our process. But the snippet, the transcript excerpt from the anesthesia resident, starts to give us some insight into why people might not adhere to the process as much as we'd like. And so when you multiply these sentiments over the more than 100 interviews that we did, you get a very rich understanding of the challenges to adhering to evidence-based practice, which is standardization of handoffs, OR to ICU handoffs. So hopefully this gives you a sense that if you mix methods together, you actually learn a lot more than if you do either one in isolation. So going back to quality improvement and implementation science, what are some of the similarities? We sort of knocked at the door of this already. Both of these fields are interested in improving patient outcomes, and they're actually both really change-oriented and action-oriented. I like the schematics that was in the Journal of the American Medical Association that talks about the relationship between precision medicine, which we haven't talked about very much, the learning healthcare system, and I would put quality improvement in here, in the learning healthcare system, and implementation science. And really the goal here is at the center is improved health, improved healthcare, and improved health systems. And there are some key areas of synergy in the lower left corner of that donut. There are key areas of synergy between implementation science and the learning healthcare system. So the learning healthcare system needs to support implementation of effective practice, but they also contextually sensitive improvement of practices is really important. And both implementation science and quality improvement are really interested in context and interested in making sure that our improvements make sense for the places that we practice. So I like to share this schematic just to show there's really no conflict here. They're all sort of related to each other. There are some areas of synergy and places that we can work together. When you think about even just the logistics of an implementation science study, this is one way to conceptualize that. This model comes from Greg Ahrens and his group, and they talked about mapping out the flow of an implementation science study, starting with exploration. In implementation science, we would call this contextual inquiry. This is understanding the environment in which you need to implement. And so you can do this with observations, you can do this with interviews or focus groups or document review. It's important to understand where people are starting and the environments in which they're practicing. Evidence-based practices, they sort of come in isolation, and there are lots of challenges to people wanting to do the right thing. So for example, in our study of OR to ICU handoffs, everyone agreed that handoffs were important, and everyone agreed that they wanted to work as a team, but we found that competing priorities got in the way of people being able to participate in those handoffs. And so if we hadn't done that contextual inquiry work, if we hadn't actually watched what people were doing and talked to them, we wouldn't have understood the degree to which competing priorities compromised their ability to participate in the handoff. And we wouldn't have been able to respond by freeing them up so that they didn't have those competing priorities. So it's really important that you explore, that you understand the context in which people. Next step is preparation and creating active implementation strategies and usually working with your stakeholders to do this. Then active implementation and then sustainment. And for those of you who do quality improvement, this will probably look pretty familiar. This looks a lot like the model for improvement. It looks a little bit like a Plan, Do, Study, Act, although it's not circular. But the idea here is that you really need to understand where you're working. You need to plan it out, put something into action, and then understand what's happened. So what are the differences between QI and IS? I've talked a lot about similarities, but there are some important differences here. So quality improvement is focused on timely, context-sensitive change. One question that might be asked in quality improvement is, how do I fix a problem that's right in front of me? And how do I know that that change is an improvement? I'm working in an intensive care unit. I have a high rate of catheter-associated urinary tract infections. How do I fix that in my unit right now? Implementation science, on the other hand, aims to create durable, generalizable, or at least transferable knowledge. And so the question here might be, how do I bridge the evidence to practice gap across settings? And how does evidence need to be adapted to fit local context? So as I explain this to trainees and to colleagues, I focus a lot on the timeliness issue because I think that's one of the easier things to understand. Quality improvement tends to be focused on change right here, right now. So, as I sit in the hospital at the University of Pennsylvania, there are hundreds of patients who need high quality care right now. So how do I do that right now? Whereas implementation science is really more future oriented, thinking about how do I understand in general how to get people to do the right thing. And that necessarily takes time to figure that out. So there is a focus on rigor, there is a focus on generalizability, there is a focus on understanding mechanistically exactly what's happening, and any of you who have done research know that that takes time. And so in implementation science, we sacrifice timeliness, ideally for something that is durable and generalizable. So what do these two fields have to learn from each other? I hope that I have not given you the impression that one is better than the other, because that is not the point. They're just fields that are aligned in some ways, but that do have different focal points. So I tend to talk about stereotypical tensions between QI and research, and so if you take the least charitable view of these fields, quality improvement tends to be fast, and we talked about the importance of rapid cycles, rapid tests of change. Cheap, you could argue with that. You don't necessarily have to go out and get a funder, but certainly freeing people's time to do things is not always inexpensive. But relative to large multi-center research studies, maybe it's a little bit less expensive. The stereotype of quality improvement is that it's imprecise, that we're just trying to fix something and it doesn't really matter how it works. Quality improvement may not have academic value or little academic value because it's so context specific, and there generally has not been a lot of regulatory oversight of quality improvement from the perspective of an institutional review board or an ethics committee. Certainly there's oversight from hospital or healthcare administration leadership. On the other hand, the stereotype of research is that it's slow, for sure, that it takes a lot of money, but that it's rigorous, it's very precise, that it has a lot of academic value and is generalizable, but there are some more regulatory hurdles to getting research done. I don't think either of those stereotypes are really spot on, but hopefully you sort of get a sense of what the typical criticisms are. I do think that implementation science has a lot to learn from quality improvement. I think the first point is that timeliness is very important. And given that both are change and action oriented, I think all of the people that are in both fields really have a sense that there is urgency around trying to get this work done. But I think the quality improvers really get that, sort of viscerally understand that, and I think IS can learn from that. Certainly the importance of context is appreciated by people who do improvement work and implementation science as well. Stakeholder engagement is something that is fundamental to implementation science, but I think quality improvement, people do this really well, that you have to figure out whose behavior you're trying to change, but you also have to figure out whose life and work may be affected by the change that you're thinking about, and really engage all potential stakeholders early on in the process. And QI, I think, is also very good at adapting to local conditions, and implementation science, we think about that, but there's still an active conversation within the field about the degree to which adaptation is appropriate, is allowable, and the degree to which adaptation may actually compromise the evidence-based practices. On the other hand, I think that quality improvement has a lot to learn from implementation science. So in implementation science, we use a lot of conceptual models or conceptual frameworks, and it really forces us to specify the causal relationships that we think are at play. And the nice thing about doing that is that if you measure all of the different constructs along a causal pathway, you can really understand why an effort worked or did not work. Oftentimes, my big experience in quality improvement operations is that if you implement something and it doesn't work, you often don't have a lot of information about why it didn't work. You're just sort of left with something that didn't work. And I think what we can learn from implementation science is really trying to step out the causal pathway so that you can kind of back up and say, okay, why didn't this thing work? And let's address the reason that it didn't work. I think implementation science does rigorous measurement really, really well, and making sure that the things that we're measuring are measured in a valid way. And I think mixed methods is also something that's fundamental to implementation science that I see being picked up more in quality improvement, but I think both doing quantitative inquiry rigorously and qualitative inquiry rigorously is something that implementation science does well. So that's it for my prepared comments. I'm going to turn the floor over to Dr. Fleisher, who's going to talk a little bit about, from his perspective as a researcher and as a chair and all of the other hats that he wears, about how QI and IS play out in the real world.
So thank you, Megan. I think that the key thing really is that we need both, that quality improvement is something we do in most hospitals, that we, as far as getting better, but understanding and therefore giving us a better approach to it scientifically that really can be generalized across multiple venues really requires implementation science. That, in fact, if you have an implementation scientist within your hospital setting, if you're someone who wants to become an implementation scientist and really do a lot of the work that Dr. Lane-Fall approached, that adds sort of an extra oomph to your quality improvement program, in that there will be a richness in the way you approach questions. From what I see in my own organization here at the University of Pennsylvania, but also when I've traveled overseas or others, that you usually have someone who can understand how to do the PDSA cycles, how to actually do root cause analyses. But if somebody wants to do culture change, that social science aspect, and move the organization forward, that really, having an implementation scientist is unique. So if I were to give the 5-minute elevator speech or the 30-second elevator speech to the CEO of a hospital or CFO, if you were an implementation scientist or wanted to hire one, such that, like myself, I have Dr. Lane-Fall, I'd say we can continue doing what we're doing and get better incrementally. But if we really want to make the jump into changing the way the culture acts, we need an implementation scientist. And really, if that's what we're looking for is a cultural change, that's the approach to go forward.
That's it for our comments. We're going to move on to question and answer session. These are just our webinar objectives again. And then for more information, we put out this edition of Anesthesiology Clinics. That's actually where the webinar came from. Free to look at these papers. And then I'll turn it back over to our organizers.
Thank you, Dr. Lane-Fall and Dr. Fleisher, for sharing your expertise with our participants. I'd like to open our question and answer session. If you would like to submit a question via the Q&A box, you may enter it now. Here is our first question. It reads, what kind of training do people need to do implementation science research?
Yeah, so this is an interesting question because the field of implementation science, we still characterize it as new, although really it's been around in some form for about 20 years. It draws from psychology, it draws from human factors, it draws from engineering beyond human factors, all sorts of social science. So there are the people who started off in the field who came from these disparate fields, and then there are the new generation who are coming up now. I would say, at the very least, some preliminary coursework in implementation science is really useful to understand the field, to understand the theories, models, and frameworks I talked about. The National Institutes of Health is really interested in implementation science. Sort of going back to the comments I made about funders, payers, I didn't talk about research funders, but they're really interested in this work too because the basic research that the NIH has been funding isn't necessarily making its way into patient care, and they want to change that. So the NIH actually funds some training opportunities related to implementation science. The most well-known one is called TIDR, which is TIDIRH, Training Institute in Research and Implementation and Dissemination for Health. It's sort of a mouthful. But there are a number of universities that have training programs in implementation science. UCSF is one of them. The University of Michigan is one of them. Penn has a K-12 in learning health systems delivery. So I would say it's worth a Google search to look at training opportunities in implementation science. There are also sort of 1 to 3 day seminars that people can take just to get a sense of what the field is and how relevant it is to them. So there are a lot of training opportunities out there.
All right, thank you. Our next question reads, what funding support is there for QI research and implementation science research?
I would characterize the sources of support as internal versus external. I think that, sort of piggybacking off what Dr. Fleisher said about health systems, there's really an incentive for local health systems and administrators to understand how to improve quality and how to do it in a rigorous, sustainable way. And so increasingly we're seeing health systems invest in science and in quality improvement research. So I would potentially start locally and see what kind of support there is for work. But if you're thinking about doing work that is more relevant to other groups, so if you're thinking about generalizable, transferable work and thinking about extramural funding, the Agency for Healthcare Research and Quality certainly is interested in improvement science and quality improvement research, but also increasingly the NIH, as I mentioned, the National Institutes of Health, are interested more in implementation science than quality improvement research, but if you can make a strong, rigorous quality improvement project relevant to health and the mission of the individual institutes and centers of the NIH, they would certainly be willing to listen. But the institutes at the NIH that have put a lot of money into implementation science include the National Cancer Institute, the National Heart, Lung, and Blood Institute, the National Institute for Mental Health, and there are a few others, but some of the most well-funded institutes and centers at the NIH have put significant dollars toward funding implementation science research. And for those of you who have a background or have been funded by the NIH before, there's actually a study section within the NIH for implementation science. It's called DIRH, or Dissemination and Implementation Research in Health. So they have put together resources for its own study section. That's how strongly they feel about it.
All right. Thank you. Unfortunately, we have run out of time for questions. We would like to thank Dr. Lane-Fall and Dr. Fleisher for presenting this exciting informational webinar activity, and we hope that you'll be able to use what you learned today in your area of practice. At this time, I would like to thank our presenters and today's audience for participating in our program. Thank you again for joining us. I hope to see you at a future webinar.